Hi, everyone. Welcome back to our Pimp My Pod podcast. This is number 6, and this is the edition just before your trauma and podopediatrics exam. So I figured I would cover um, some topics that would be pertinent and give you some helpful hints as well. So let's get right into this and try to be quick. I know your time is definitely slim given all the studying you're doing. Okay, let's start with the pick of the week. Now, this is going to be really mundane, and for those of you who don't wear glasses, um, that's okay. Maybe this will be useful for you too. So, my pick of the week is to, for students, when you're on your clinical rotations, to use a strap to attach your glasses to your head so it doesn't fall. I'll tell you a quick story. When I was a resident during my first year, I wore glasses as I do now, and I was on my general surgery rotation, and I was assisting in a case, and I was cutting suture for the surgeon, and I was so focused that there was a point where I was trying to cut the suture, and I kept missing the suture, and the attending was like, "Man, cut the suture already." I'm like, "I am. I'm trying." And I realized that my glasses had been sliding down my face, and I no longer had 20/20 vision. I no longer had good visual spatial ability, and God forbid my glasses could have fallen into the field. So ever since then, I wear something on the back of my glasses, and what I have now is this, and I find this to be pretty useful. So let's see if I can show my version of this. Um, so I just pull, and then it extends while I'm pushing on this little tab, and then when it's on my head, on the glasses, I just basically just pull and tighten it, and it goes behind my head and stays on. And it's very comfortable. It comes off very easily. It doesn't damage the glasses. So that's my pick of the week. Don't let anything fall into the patient's field. Definitely a good idea. Okay, let's get to some housekeeping. The housekeeping is going to cover your um, podopediatrics stuff, as well as a comment about trauma. So let's start with the trauma. First, to clarify the Rudy Allgauer classification for pilon fractures. I stole this picture off the internet. I like it. It's very nice, clean. You can see that there are 3 types. You can see that it's really easy to say bad, badder, and baddest. But the type 1 is fractured and non-displaced. The 2 is fractured and partially displaced. And the 3 is significantly displaced. So um, when you're looking at pilon fractures, you really can see large gaps in between. It doesn't have to be totally obliterated to be a type 3. It just needs to be significantly distracted, and then you'll be able to classify this. Very easy kind of classification to use. Okay, this was a conversation piece during our review session this past week, and this is a slide from your lecture that says TEV treatments non-surgical, and your slide on this lecture does not currently say Ponseti manipulation and casting, but this slide, without saying it, is actually talking about this. Now, I guess it might be important or reasonable for you to ask, well, what does Ponseti mean? Ponseti is the name of a orthopedic surgeon named Ignacio Ponseti, who was a Spanish surgeon who moved to the United States and practiced in Iowa. And he created or came up with this manipulation and casting technique that was essentially 95 to 96% successful in children with idiopathic clubfoot. You remember, idiopathic means we don't really have an explanation for it. It's not that they have a neurological condition. It is that we just don't know what the cause is. Usually it's a packaging or positional problem in utero. So Dr. Ponseti has passed away in about 2008, I believe, uh, and his method was used by a small number of people for many years throughout the 60s, 70s, 80s, and it really wasn't until around maybe the late 80s, 90s that his method really took off. And it was unfortunate because the methods that were used previously were highly unsuccessful. And I'm going to talk about this method of manipulation and casting in just a minute, so we can kind of better understand what this method really is. So before we get to that, I want to point out just a couple of things, a couple of biomechanical principles that I think are helpful in general, but well, I hope help you understand a little bit more about the cavus foot that you see in a child who has clubfoot. So what I'm showing you here are two different feet, the forefoot to rear foot relationship of a person with a pes cavus on the left and a person with a planus deformity on the right. And both of these feet are sitting with the heel bisection sort of perpendicular to the ground. So the only thing that's going to vary in this image is the forefoot. And you can see that the pes cavus foot has this forefoot valgus, and it's worsened by the plantar flexion of the first metatarsal. In the planus foot, it's actually almost perpendicular forefoot to rear foot, but it's a slight varus deformity. So you remember that a forefoot varus will mean that the medial side of the foot is elevated from the ground in relation to the lateral side of the forefoot when the foot is in the neutral position. Don't worry about the neutral part. Let's just stick with the forefoot relationship to rear foot. So if you have somebody with a clubfoot and they have a super cavus deformity, which is really what a clubfoot is, you're going to get this forefoot valgus relationship, but you'll remember that the deformity of a clubfoot is varus, an inversion of the heel, so that's also varus, equinus of the ankle. And remember that the forefoot to rear foot relationship can be valgus, like what we see here, but the whole foot could be rotated so that everything is in varus, which is why they describe it that way. So you're going to see in a minute that if you're trying to turn a forefoot valgus into a relatively forefoot varus, like when you're doing the casting, you're actually trying to take a really severe cavus deformity and turn it into a relatively more planus deformity. If you're going to do that, then you need to rotate out the valgus deformity, and that means you're going to take the forefoot and rotate it into varus. Okay, so that is a major difference that Ponseti had when he came up with his method. So just keep that in mind when we start to talk about the clubfoot. Now, there's this concept I also want you to think of is just an extension of what I'm talking about. So this concept of the lamina pedis was actually first described by a gentleman named McConnell back in like 1944. And for some reason, we didn't really pay much attention to it until relatively recently. So he described the foot as this skeletal and ligamentous structure that functioned by rotating or twisting on itself. And you can kind of see that in letter A there, that rear foot is stacked on top of itself. So on the right side of the image, you can see that twisted plate is perpendicular to the ground on the right side. And that represents the calcaneus and talus sitting stacked on top of each other. And we know that that's kind of what normal is. Now, if you then twisted that plate in the middle, which is B, you will see the creation of an arch and essentially a forefoot valgus deformity. And then if you were to untwist that, you would get uh, a flattening of this plate, this lamina, this plate that's there, and you would be creating a pes planus. So A would be like the neutral foot, B is a cavus, and C would be a planus foot. And you can see that as you untwist the planus foot in C, you'd have to create a rear foot valgus in order to do that. And you would also be creating a relative, so forefoot to rear foot, relative forefoot varus. Okay, so that's where forefoot varus is really more commonly seen in the planus foot as opposed to the cavus foot, despite the description in Ponseti and in this class that you have a cavus and a varus. Really, most people are saying that the varus of the foot is coming from the entire foot rotating, not necessarily the forefoot to rear foot relationship. Okay, now here's an example of a child with a mild Talipes equinovarus or clubfoot deformity. And don't worry about the little scratch that, kids get scratches all the time. If you look first at the bottom image, you can see that the heel is a little rounded and it's rotated into a varus position. So more of the plantar surface of the heel is facing you, which means it's in varus. The other thing that you can see pretty well is that the forefoot is plantar flexed. So you can see that the shadow underneath the metatarsal head area is more so than the rest of this. And that area corresponds to the forefoot plantar flexing, and it's also adducted slightly. Not much, but slightly. You can see that the hallux sits below the second digit. So that means that this is a plantar flexed first metatarsal. So the child's whole foot sits in varus. The child has a cavus, mostly in this case because the first metatarsal is plantar flexed. And there's also an equinus position. So you can see that the foot is plantar flexed, and that is a relatively fixed position. So the calcaneus is in a plantar flexed position. If we were to see the bones, the talus would be more parallel with the calcaneus, and the Achilles would be tight. Okay, so that's your classic appearance of a clubfoot. Here's another one. This is a little older, and the child is walking. And you can see the same thing as we saw on the last image, just much more severe. This is a significantly more severe deformity where the child is now walking on the lateral side, actually the dorsal lateral side of the foot. The forefoot is plantar flexed and adducted. If you look at the child's left great toe, you can see that it's both plantar flexed and somewhat adducted, and that is because the abductor hallucis is really active, as well as the flexor hallucis longus tendon. So this child is adducted in the transverse plane. He's plantar flexed at the ankle, and the Achilles is contracted. You can also see the adduction on the right foot where that crease is on the medial side of the arch. And then the forefoot, it's a little hard to see, but he actually has a bit of a forefoot valgus where the first metatarsal is plantar flexed, slightly more. But the whole entire foot is sitting in varus, which again is why this is described as a varus deformity. So I want to show you now a small series that kind of illustrates how the Ponseti method works. So I'm going to show you a picture of actually one of my attendings when I was a resident, and he had a patient with a clubfoot, and this was a child who actually was on the third or fourth casting and manipulation visit. So it was one cast a week for about 5 weeks. And what he's doing is, we're going to focus on the child's right leg. So his right hand is holding the forefoot, and he is inverting the forefoot. So he's getting rid of the forefoot valgus, and he's inverting that. And then while he's inverting it, he's going to abduct the foot. But you'll notice that with his left hand, his thumb is actually sort of sitting just a little tiny bit below the tip of the fibula. So he's now, his finger is actually on the lateral side of the talus. It's very small. So remember, you have to be very careful. And he's going to use that thumb as a fulcrum to rotate the foot around. And as he's doing that, so now he has created a forefoot relative, forefoot varus. He's abducting the forefoot, actually he's abducting the whole foot, and he's rotating it around the talus. So when he does that, the foot will then straighten out, and he's not trying to get rid of the equinus. Okay, remember, that's the last step in Ponseti casting, is to get rid of the equinus. So he's not actually trying to dorsiflex the foot at all. So he's correcting two planes at the same time. Okay, then we prep the skin. You can see that that foot is a lot straighter than a supinated inverted foot. You can even see that the foot's sitting a little bit more at 90 degrees, a little closer to neutral. So again, we put on skin prep there to keep the cast on. Where that little tan color stuff is a stockinette that goes around the thigh. Then there's one that goes around the foot. It's very small, so you have to use very small padding. And then here we are putting on the cast padding or web roll onto the child. This is like a 1-inch web roll. So as my attending holds the foot, I am wrapping the leg all the way up to the thigh. So we're putting on an above the knee cast. The reason for that is that very small children wiggle out of below the knee cast really easily. So it has to be above the knee cast. So he's holding the child in the corrected position, which is key. And then I do the padding. Okay, then comes the casting. And again, so now you can see actually he's holding the forefoot inverted with his right hand. And then the left hand, you see where his thumb is. So his thumb is on the lateral side of the right foot. And he is abducting the foot around his thumb, which is essentially around the talus. There we are, kind of holding things as we keep going. And we roll up the leg. And really, you just get the foot and ankle stabilized. And once you do that, you can actually finish the cast after things start to harden up, and you can obviously let go. So there it is, almost finished. And when we get to the end, there's our last bit. So we roll down the stockinette to kind of keep things nice and clean. We want to try to have a little bit of extra padding for the child so that we avoid the cast rubbing against the child's skin. And you also obviously have to be able to change the child's diaper and all those kinds of things. And then so as we finish, there's the final product. And you can see that the foot is pretty much slightly plantarflexed, but generally straight. So we don't see heavy inversion at this point because we're a little further along in the process. So this is, like I said, this is the third or fourth cast. And the forefoot to rear foot relationship is about perpendicular. The foot is abducted, and it's actually abducted about 75 degrees, and you kind of keep it that way for months afterwards. Okay, so that was clubfoot. Now to move on to a case with a trauma case, and I'll tell you about a case that I just had recently. We actually took care of this patient this past Thursday, so that was maybe 4 days ago. So this 61-year-old female is a diabetic who has end-stage renal disease on peritoneal dialysis, asthma, hypertension, GERD, and gout. Yes, she is very healthy. She's allergic to sulfa, and she takes a slew of medications, one for multiple medications for each one of her disorders. She was in her house, standing, doing some laundry, when her ankle went out from under her. She fell and had significant pain. She was not able to walk on her foot immediately, or when she went to the emergency room. So remember that that is a rule set, the Ottawa ankle rules. She had malleolar pain on both sides. She had an inability to walk at the time of the injury, and she could definitely not perform 4 steps in the emergency room. So that means that she would benefit from having radiographs in the emergency room. Now you can also see a couple of other things. She had been seen in the emergency room. She was put in a splint, which was not terribly good. Her fracture was reduced, and then she was sent to see me. Now you'll notice her soft tissue envelope, or the skin and soft tissues around her ankle joint, are intact. She does not have any open fractures. So if she did, this would be classified according to the Castillo-Anderson classification. If it was less than a centimeter and clean, then it'd be a 1. If it was greater than a centimeter, it'd be 2. So if it's 4 centimeters and clean, it would be a 2. And then if we had more significant damage, then it would be a 3. If there's vascular compromise or periosteal stripping, then we start classifying this into an A and a B, and it becomes a more emergent situation. Also remember that with the Castillo-Anderson classification, if it's an open fracture, she would need antibiotics. So 3 to 5 days of antibiotics. This patient has a closed fracture, right? So there are no open lesions. She does have ecchymosis, and she does have edema. So that may limit our desire to take care of this patient surgically right away. So I'll tell you that this patient did have surgery, but you can see that she has ecchymosis, but there's no other soft tissue trauma. She doesn't have blisters or bulla, which means that her edema is reasonable but not significant. We're not too worried about damaging the soft tissue envelope. So from a trauma principle standpoint, she is stable. So she obviously was not kept in the hospital. She was able to come home and then come to see me a couple days later. We need to now control her edema. So she was placed into a Jones compression posterior splint, which I'll show you what that ended up looking like in just a minute. So remember that the Jones compression dressing consists of a layer of web roll and then ACE, and then a second layer of web roll and then ACE. So WAWA, W-A-W-A is the sort of mnemonic that people use. And then the splint is placed on, and another roll of ACE wrap to hold the splint to the foot. Her fracture was reduced. So in this case, we held her foot in the Quigley position. So we grab her hallux, lift up her foot while she's relaxed and the knee is bent. And this will cause the foot to roll into supination and adduction, and that oftentimes will reduce the fracture. Now, remember also that if for some reason there were non-palpable pulses, like we thought that maybe a piece of the fracture was pushing up against the posterior tibial artery, then this would be a immediate emergent procedure that would have to be done immediately. The other part of this is about compartment syndrome. So keep in mind that this edema is not too bad, but when we do our examination, we noted that this patient did not have she was in pain, but she did not have pain out of proportion to the injury. She did not have pain on passive flexion of the digits, which is actually considered one of the most sensitive and specific methods to diagnose compartment syndrome. We did not use a needle manometer to check her because our clinical suspicion of compartment syndrome was relatively low. Okay, now here's her fracture, and you could see that she has. I'll show you the lateral in just a minute, but you can see that on the AP view, which is on the left, and the mortise view, which is on the right, that she has two malleoli that are fractured. And the fibula fracture is a spiral oblique fracture. You can actually see what looks like two fracture lines, as well as a small piece of bone that's sticking out from the medial side of the fibula. That's called the butterfly fragment. So, the first thing is about stability. So, remember about your principles of stability. So, a straight transverse fracture would be relatively stable, and that's that tibial fracture, the tibial medial malleolar fracture, would be relatively stable. The fibula fracture, on the other hand, has, and you can see this very well on the mortise view on the right, that the distal part of the fibula has migrated proximally. So the entire unit, and you can tell this by the talar dome, has moved laterally because it's lost the buttressing effect of the fibula. And the fibula has moved proximally. So we have a proximal and lateral migration. So it has displaced in that direction. You can see also that the medial malleolus has displaced laterally as it went with the talus. So if I was going to ask you to classify this, then first you'd have the Danis-Weber classification. And the Danis-Weber classification says that A starts below the level of the ankle joint, B at the level of the ankle joint, and C above. And this fracture of the fibula starts at the level of the ankle joint. That means this can either be an SER or a PAB. And since this is a spiral oblique fracture with a spike which would be posterior, you can kind of see that a little bit on the mortise view, then I know this has to be an SER. Now I know that SER fractures always start with damage to the anterior inferior tibiofibular ligament, or if the ligament wasn't damaged but the bone broke, then you would have a Tolot-Chapeau fracture if the tibia fractured, or a Wagstaff fracture if the fibula fractured. Now I don't see either one of those on this, so I'm assuming that the anterior inferior tibiofibular ligament has ruptured. That would be an SER1. Then going around in a clock, like a clock shape, the fibula fractures next, that's an SER2. What I cannot see on this radiograph yet is a posterior malleolar fracture, and that would be an SER3. And then finally, you can see that the medial malleolus is fractured, and that's an SER4. So here is the lateral view, and this is really hard to see because of those kind of lines that are there. Those lines are actually called moire lines, and those are there because the camera and the screen on the computer are of different sort of cycles, and so you start to pick up those lines. What I will tell you is that this patient does have a small, non-displaced posterior malleolar fracture. Okay, so you'd have Danis-Weber B and SER4. It would be your classification for this patient. Okay, so let's go forward. Now I'm going to take you through a short tour of the surgical procedure itself. We took some pictures during the surgery. This is the patient in her Jones compression posterior splint. You can see just how fat that thing is. It's huge. We happen to use a very large splint material in our clinic. There are smaller ones, but she has multiple layers there. Okay, now what I'm showing you first on the left is the kind of general overall view of the patient. You see those little purple things, those are there for padding of various parts of the patient. You can see one on the left foot. We don't want to create ulcerations while we're doing this. Then also there are three objects. There's white web roll, there's a tan or brown Coban, and then a black, that's a tourniquet. So we're going to put a tourniquet on the patient's thigh, up way above the ankle fracture, so on her thigh. And then the tourniquet's going to go on the web roll. The web roll's there to protect her. And then I personally like to use Coban wrapped around the whole thing because it prevents uh, the it prevents migration of the tourniquet. Now, if you look at the patient's foot on the ankle on the sides here on the right sides, you can see the medial and lateral views, and she has less edema than she did before. You can also see that her ecchymosis is a little bit more well defined, maybe even a little bit more severe than previously. And that happens. It develops, the edema and ecchymosis develop. But we were able to eliminate a good bit of that edema that she had. Originally, the dorsal surface of her foot was really swollen, and we were able to get rid of that. So we protected that soft tissue envelope for a few days. She's about almost 10 days out from her surgery when we. Almost 10 days out from her injury when we did her surgery. This is our C arm. You can see why they would call it a C, and this is used for us to do intraoperative fluoroscopy. So this is one of my residents, Dr. Lynn, who was our primary surgeon on the case, and she is, you can see that she's wearing lead on her body as well as a lead shield around her thyroid. Obviously that is to protect her. And she's got her hands in a nice position where she is about to put on her gown after she has scrubbed and she is sterile. You cannot drop your hands below your waist, and you can't bring them above your shoulders during the surgery, so you're kind of kept in that zone, and she's doing a good job keeping her hands where they're supposed to be. Now this is kind of showing prepping and draping. So the patient, the limb has been cleaned with cleaning solution, and then we are draping the patient, making sure everything is all protected, all things are all ready to go. One comment I can make to you that you cannot see here is that the right foot, where the ankle fracture is, that's the side, the right foot is actually sitting on about 4 rolls of towels, of blankets, and that lifts the foot and above the level of the other one, so that when we are doing radiographs or taking fluoroscopy shots, the other side does not get in the way. This is our back table. You can see a good number of instruments. Really hard to see, but on the right side image, on the left side of that image, so closer to the center of our screen, is our fixation technique or fixation equipment that we're going to be using. Plates and screws and that kind of thing. Okay, so the first thing we do when we start this is to mark out the anatomy that's important. And we're on the lateral side. We're looking at the fibula. My resident has marked out the fibula, and she's also marked out where the fracture is. That's kind of on the proximal side of this. And there's a dotted line, which is going to be where she is planning to place her incision. So we mark out everything. We want to make sure that we keep in mind anatomical structures that are at risk. So remember, we have the perineal tendons, we have the sural nerve. We want to prevent damage to those. So this incision is a kind of utility incision that really lets us get right to that. And then on the medial side, this one's a little harder to tell because she started drawing it a little weird. But she palpated the most distal aspect of the medial malleolus, and then that darker blue line is the ankle joint line itself. Then there's a line that runs longitudinally, which is what her planned incision is going to be. Then we're going to start on the lateral side and then move to the medial side once the lateral is mostly finished. So we are elevating the foot here, and we are exsanguinating, or getting rid of as much of the blood as we can before we put up the tourniquet. There are two ways to do this. You can use a rubber bandage called an S-mark bandage, which we did not use here because we don't want to disrupt any more of the fracture than we have to. So they're elevating the foot for 3 minutes. That allows the blood to leave most of the leg, and then we put the tourniquet up. In this case, we put it up for 3 to 300 millimeters of mercury. That's a pretty standard number. It's 200 above. It's really 200 above 100. If the what you can do is you can pick a number like 300, or you can look at the patient's systolic blood pressure, and typically it will be 100 above the systolic, or for an ankle tourniquet, or 200 above the systolic for a thigh tourniquet. So it's one way to do it. Okay, so she now starts by making her incision and dissecting through this. And I'll see if we can see anything good on this. So she started a first incision, and then now she is starting to make a second incision and dissect down. So she starts in one spot, and then she continues to move her way down the fracture line until she starts to open up the skin. Okay, now this is a little bit deeper down. She's opened up the skin and the subcutaneous layer, and she is now opening up a channel where the fascia is. That would be the next. So she's using a scissor to push down from proximal to distal, and she's opening up. And what she's doing is called a layered dissection, and she's trying to be as atraumatic as possible. She's creating a pocket in which to do the work in order to fix the fracture. And she also wants to be able to close that same pocket of tissue in layers. There we are. After we've gotten it open, you can see there are retractors holding the skin open, and then the person holding the pickups there is pointing at where the fracture is, and we have a spiral oblique fracture with a posterior spike, and that's our fibula fracture. There we are again. Now what we've done is we have reduced this fracture. So in order to do that, the surgeon grabs the heel and inverts and plantar flexes the foot, and then while we do that, we manipulate the fracture, the fibula, into an anatomical position. When we think we have it, we then clamp it, and that's what that clamp is doing. It's actually holding that fracture together, and you can see that kind of on the x-ray. Now, I want to point out one other thing. So, two things. First, there is a K-wire that you can see on the radiograph, and that was extra provisional temporary fixation to keep things from moving. Because as it turns out, this fracture was heavily comminuted and did not want to sit still. So we put that in to help keep the distal part of the fibula from moving. Now, the thing I want you to notice is that we have not done any manipulation to the medial malleolus. Nothing was done on the medial side yet. And you'll remember that when you reduce the primary fracture, and that causes the secondary fractures to move back into their normal anatomical location, that is called the Vassal principle. And you can see this pretty much demonstrated, that the talus moved back medially, and the medial malleolus fully reduced itself back to where it's supposed to be. That's the Vassal principle. So this is the medial side now, and they had fixated the lateral malleolus, which I'll show you the radiographs of that in a minute. And then we opened up the medial side, found the fracture, and 2 screws went across that. Okay, so here's the final result at the end of things. Let's first look at the left-sided picture. That's the AP view of the ankle. And what you can see first is a long plate that starts from mostly the tip of the fibula and moves proximally. What you don't see are screws outside the plate that are holding the fracture together. So remember, when you fix a fracture, you put compression screws in, and those compression screws would allow for primary bone healing. But in this case, because our fracture was so unstable, we could not get screws across the highly comminuted bone. And you can see the severity of that comminution on the lateral radiograph, the one on the right. And if you look behind that plate, you can see large sort of pieces of bone. Those bone pieces are too small for us to get fractures or to get screws into. We would have preferred a fracture that wasn't comminuted. Now, because of that comminution, and we cannot put screws across the fracture to achieve primary bone healing, we are using that plate as a bridge. So this is the function of the plate is as a bridge plate. And remember that you can have a bridge plate, a buttress plate, a compression plate, or an anti-glide plate. Now we put this plate on the lateral side because we didn't find any need to put it behind. So it didn't function as an anti-glide. It is bridging the comminution and holding the distal piece to the plate and the proximal piece. So we did not have compression screws through this. Now on the medial malleolar side, you can see two screws that are running there. And those screws are actually grabbing the posterior part of the tibia in order for us to have compression. Now, if you look carefully at those screws, they're pretty long. And those screws have heads, and they're partially threaded, and you can see the threads distally. So we are lagging the fracture to compress it and have primary bone healing. And these screws are lag by design. So instead of under drilling and then over drilling to create that space to allow the screw head to push against the medial malleolus and compress it, we've just used these screws here, which instead of you having to over drill it, these are lagging as well. So they're doing exactly the same thing as a screw that we would have lagged by design. Now the other two things to notice are there are two other screws. There are screws running transversely across from the lateral side to the medial side, and those are syndesmotic screws. Now you'll recall that during a surgery you can check the syndesmosis by doing a few things. One of them is the cotton hook test, where you take a hook and you grab and try to pull that fracture or the fibula away from the tibia, and you'll see if there's a gap. We did not see that. You could evert and dorsiflex the foot, which is actually considered a more sensitive way to look at this. And we did not see that, actually. So you might say, well, okay, if the syndesmosis is intact, why did you bother putting in those screws? Well, you'll recall that medically, this patient is diabetic with end-stage renal disease with a bunch of other problems. And these two screws will give us a little extra stability into the fracture to hold things together in case this patient starts to go into Charcot. I mean, really, I'm trying to prevent this patient's very high risk of Charcot from occurring. Now, the other thing I want you to notice is that we have an anatomical alignment of the ankle joint. And remember, that was the goal of our surgery in the first place. Now, as much as I would like to fix all those little pieces of bones of the fibula back together, that is really not as important as having a nice, stable, anatomically aligned ankle joint. You'll recall that there is a concept called tibio-talar contact area. And the more displaced the fracture. So anything more than two millimeters, or I'm sorry, anything more than a millimeter is going to reduce your tibio-talar contact area by 42%. If it's 2 millimeters, it's actually going to decrease it by 69%. So what that means is that you'll have focal areas of the tibia pushing on the talus, and that will erode the cartilage, and you'll get a more rapid onset of arthritis. So that's why we are really trying to accomplish as close an alignment, anatomical alignment, as we can. A couple comments. Remember that with the bridge plate that we're using, we are now expecting to have endochondral or secondary ossification occurring on the fibula, which is good because it is possible to heal that. On the tibia, we're expecting primary bone healing. What might happen if there is motion at the one of those pieces or in your fracture, if there's motion and you're getting secondary bone healing, you might get a bone callus formation. So remember that bone callus is a sign of motion and secondary ossification. And in many cases, especially if the strain on that healing fracture or osteotomy is too great, greater than 10%, then this patient is going to end up with a non-union. Now, one last comment about this before we move on. Remember that we were trying to follow the AO principles. So we had we had an anatomic dissection that you saw. We tried not to damage the tissues. We gently manipulated tissues. We maintained vascular supply. We have anatomical reduction and stable internal fixation. So we moved the ankle joint through a range of motion at the end of the case, and everything was nice and stable. So we followed our AO principles, and we are more likely to have a successful result with this patient as a result of that. So this is at the end there. You can see we were stapling the medial side and the lateral side. That's what we principally did. After we closed the layers with stitches, we finished this up with staples. There we are. Kind of finishing things up. Staples. The tourniquet's already down. That's why you're seeing some extra blood, because patients bleed when you let tourniquets down. There we are. Then putting on a posterior splint and a new Jones compression dressing, and then finishing things up. Foot at 90 degrees to the leg. Good compression to help control the edema and reduce skin healing problems. We put on 2 splints in this patient's case, and you can see there's one splint running sort of transversely across our picture. That wraps around the heel along to the other side. That is a sugar tong splint, and then there's another one on the bottom of the foot wrapping up behind the calf, and that is our posterior splint. Then we attach them both, and we wrap them up with ace wrap, and we're finished. Okay, so let me give you some final conclusions on this, and kind of talk about a musing that I have here. And I want to try to give you some positive reinforcement. And there's this phrase which you may have heard of: "This too shall pass." It is, no one knows exactly where this comes from. It may be biblical. It's thought to come from this fable of Solomon's seal by Edmund Fitzgerald. And I'm going to read a little part of this to you, and then we can talk really quickly about it as we finish things up. It is said, an Eastern monarch once charged his wise men to invent him a sentence, to be ever in view, and which should be true and appropriate in all times and situations. They presented him the words, "And this too shall pass away." How much it expresses, How chastening in the hour of pride, how consoling in the depths of affliction. That's from Edmund Fitzgerald. And it's those last couple of words, the depths of affliction, that I feel like you personally may um, feel like you have some beef with, or some acceptance of, I guess. I want you to remember that you are about to go to finish half of your PMP4 class. You're only 2 sections away from finishing this class entirely. You're almost done with your first 2 years of podiatry school. These things shall pass. You're going to start your third year, and you'll have uh, so many new experiences and so much to look forward to. Remember why you're doing this. You're trying to become a physician. You're going to help people. Um, you're going to have a reasonable income and all those things that'll go with it. And what you're suffering through now could be so much worse. You could be flipping burgers at some joint somewhere instead of studying the human body and the functions of people and how they work. I know it's difficult. I believe that you will do great. And just keep in mind that what you're suffering through now is only temporary, and this too shall pass. On that note, I thank you very much for your attention. Again, please feel free to send me text or emails. If you need anything, just let me know.